Our system actually encompasses about 1.9 million visits per year. We see over 500,000 patients in our hospitals. We are the safety net for Harris Health System and for Houston region, the third largest healthcare safety net hospital in the nation. And we're so very proud to be able to be using MCG. We have found that the Indicia product can be translated into a myriad of departments. We use it in the referral center. We use it with our cases where patients need to see the subspecialist, where a subspecialty is necessary. We want to make sure that those patients are moving progressively from the primary care physician into the specialty service and done by criteria. This has allowed us to specialize in just those cases that really require that specialist, because unfortunately, about 60% of our payer is charity. And so we have quite a large burden of responsibility to our county of Harris, and we want to ensure that the patients that are the most acutely ill and do have the necessary criteria met see the physician that is necessary. We also use it with denials, so we have a very good, robust team there that is doing real-time denials management, appealing for about 96% return, which is very, very excellent for a healthcare system. We use it with the pre-authorization teams, and we have a pre-authorization team for inpatient or hospital stay, and as well as the ambulatory setting. And this has allowed the Indicia standpoint of the standalone system to really be able to interact with those patients, providers, and payers in a preemptive way so that they can ensure that those patients have all the criteria met and that they get their procedure in the timeliness that's necessary. Again, because of our intense volume, our burden is large, and so we want to ensure that we are giving the patients just the right care at the right level. We use it also with utilization, and utilization is the department I work for, and it is a system-wide spread that goes across the continuum of both ambulatory and hospital stay to provide a medical necessity program. That program is involved on every level of the continuum, looking to ensure that we have data that is excellent, and we are thankful to say that we even were one of the finalists in the Doyle Award in 2018. So lastly, but not least, we do use it in our hospital setting for the case managers. And the case managers from the time of the emergency room, 24/7, are sitting with the physicians, incorporating that process of the MCG review into their workflow in a real time so that physicians can make that call for where that patient would best be in the level of care needed. We also have the ongoing inpatient case managers that are managing, as well as social workers that are doing a dual role with discharge planning as well as concurrent reviews, ensuring for a length of stay. We've recently developed a collaborative for length of stay, which will incorporate our case managers, our utilization management team, as well as our CDI, our continuous documentation and improvement specialists, so that we can collaborate collectively to get that patient to the best level of care outside of the hospital setting. So we're looking to improve with our work in the ambulatory care setting with transition of care, and that's why I'm here today. It's easy, it's quick, I can move forward. My teammates are able to adjust to my review and see where I was, and they can pick up. And also our senior leaders are using this criteria to make strategic decisions around the variances that we're seeing. So we are able to affect change in the hospital settings, in operations, to identify needs over the weekend moments, or actually we're looking at contracting out some services so that we can affect change and get the patient to that next level of care. They're a much happier group because they don't have to go to the doctor and talk with them so often because there's no need. They can see the criteria as adjusted to the patient's need. So it's very nice.